Good afternoon, dear guests, speakers, and participants. On behalf of the Children's Cancer Center of Lebanon, CCCL, it's our great pleasure to welcome you all to the HPV conference. We are honored to have such a distinguished group of experts and advocates here today to share knowledge, exchange ideas, and drive positive change in the field of pediatric oncology. Through insightful discussions, informative presentations, and collaborative efforts, we aim to advance our understanding, enhance prevention strategies, and improve treatment outcomes for affected individuals. Our agenda for today includes short speeches, followed by engaging panel discussions featuring experts in the field. We encourage active participation, open dialogue, and the sharing of experiences and best practices to enrich our collective knowledge and drive impactful change. Once again, I extend my warmest welcome to each one of you. Now it's my pleasure to invite Mr. Raza Fasaili, the chair of the board and a founding member of the Children's Cancer Center of Lebanon, to deliver his opening speech. Please join me in giving a warm welcome to Mr. Raza Fasaili.
Dr. Randa Ahmadi, Director of Primary Healthcare and Social Health Department, representing the Minister Dr. Firas Abiad, Minister of Public Health, Dr. Abdel Nasir Abu Bakr, World Health Organization representative in Lebanon. Ladies and gentlemen, colleagues, health professionals, we would like to welcome you to this HPV conference in collaboration with UBMC, with sponsorship from MSD and the Health Equity Catalyst, founded after the launching of the NCP in July 2023. We are privileged to have received the patronage and support of His Excellency Dr. Abiad, and would like to thank our distinguished speakers, including government officials, healthcare professionals, researchers, and advocates. This conference is an urgent call to action to confront the challenges posed by HPV and to advance our collective efforts towards its prevention and control in Lebanon, to learn from our global partners and the achievements so far of the WHO initiative of eliminating cervical cancer, launched in November 17, 2020, and its causes. Throughout the next couple of hours, we will hear from esteemed speakers and experts who will enlighten us on various aspects of HPV-C, its prevalence, transmission, prevention, and the latest advancements in screening and its control. As we progress through the agenda, let us keep in mind our shared goal to impact knowledge and to pave the way for effective HPV prevention strategies in Lebanon and beyond by actively engaging in discussions, sharing your insights, and fostering collaborations to strengthen our fight against HPV. Thank you for your commitment to this vital cause and for attending this conference.
Thank you so much, Mr. Asali. It is with great pleasure that I invite Dr. Hassan Salah, Executive Associate Vice President for Business and Finance, Chief Medical Officer at AUBMC, Director of the Children Cancer Institute, CCI, and Professor of Pediatrics and Adolescent Medicine.
Thank you.
Good afternoon. I promised to have a very, very short speech. I'm accused, I talk a lot. This time I'm going to be very brief. Dr. Randa Ahmadi, representing His Excellency Dr. Firas Abiad, the Minister of Public Health, the members of the Board of Directors of CCL, distinguished speakers, ladies and gentlemen, dear colleagues. It's really my pleasure to welcome you on behalf of the American University of Beirut Medical Center, the Children Cancer Institute, with the partnership of CCL Charity Foundation for this very important conference. I think this conference has a special value because of the importance of its impact. And I'm not going to go in details, but as you all know, the human papilloma virus related diseases, particularly cancers, cervical cancers, and other cancers, are so important as a major burden, not only on the communities, but at the level of the nation and the region. I'm going to give you a few figures about how important the burden of the HPV-related cancers. There are about 660,000 cervical cancers only, and half of them almost, or maybe a little bit less, they die from the disease. I'm not talking about the other than cervical related cancer, HPV related cancer, mouth, throat, other cancers. Actually, in US, they have really great statistics, and at any time, they have now 43 million people who have the HPV infection. Every year, 13 million Americans get the HPV infection, which is really major. And if you look at the burden as far as the cost, it is $2.3 billion a year. The cost for a patient who has precancerous cervical cancer is at least $5,000. The cost for treatment of a lady with cervical cancer is up to $100,000, particularly we're talking about surgery, radiation therapy, chemotherapy, targeted therapy, immunotherapy. The burden is really major. At any time in US, they have per year at least 45,000 HPV-related cancers. The vaccination for HPV has major impact, and there are great statistics about it. In US, it went down the rate from 12 per 100,000 women to 6 per 100,000. So it's about 50%. So this is the impact of the HPV vaccination. And in our developing countries, this is even more important, because we don't have the resources, we don't have the financial support for patients who have cervical cancer. And I believe this conference will have a major impact, not only because I'm sure with all the distinguished speakers and experts will put good recommendation, but we are determined, and I need your full support for this, to have an action plan for the screening, early detection, and HPV vaccination in Lebanon, for girls who are between 9 and 14 years of age through to 26 years of age. And now in many countries, they are vaccinating boys, not only girls, because this will prevent the spread of the HPV infection. I know that the conference time is limited. There will be many topics about the early detection, screening, vaccination, the challenges. At the end, there will be very important recommendation and a practical action plan. I would like to thank the organizing committee for this great conference. I would like to thank the distinguished speakers and their contribution. And I'm sure as a group, we will be able to put a plan with the support of the Ministry of Health, the government, the community, charity foundation. We're going to make a difference for HPV-related cancers and diseases. Thank you very much.
Thank you so much, Dr. Sulh. It's an honor to invite Dr. Randa Hamedi, Director of the Primary Healthcare and Social Health Department, as the representative of the Minister of Public Health, Dr. Firas Abyad, to deliver her speech.
مرحبا صباح الخير. Thank you very much for the invitation. Actually, it gives me great pleasure to be with you and to attend such an important conference. So on behalf of His Excellency, Dr. Firas Abyad, Minister of Public Health in Lebanon, and on behalf of the expanded program on immunization at the Primary Healthcare Department at the Ministry of Public Health, I'm honored to be with you today, and specifically with CCCL, who is pioneering not only in the treatment of children with cancer, but in planting hope and positive vibes, and today in bringing together leading experts and stakeholders in the field to raise awareness about human papillomavirus and promote preventive strategies. Today, I want to emphasize the critical importance of immunization in this regard, not only as a cornerstone of public health, but also as a vital entry point to primary healthcare services that come to play a pivotal role in the prevention, diagnosis, and management of HPV. So whilst 60% of countries have introduced HPV vaccine, 60% of the global burden of disease is in countries that have not yet introduced it. And this is very alarming. That is why immunization stands at the forefront of our efforts to safeguard the health and well-being of our communities, particularly our children. As we strive to achieve the Sustainable Development Goals and global health targets, it's essential to recognize the pivotal role of childhood immunization. And immunization not only protect individual children from vaccine-preventable diseases, as Professor Solh has already mentioned, but also contributes to broader societal goals, such as reducing child mortality, promoting equity in healthcare access, and advancing overall health outcomes. Currently, immunization prevents 3.5 to 5 million deaths every year from diseases like diphtheria, tetanus, pertussis, influenza, and measles. So in Lebanon, the Ministry of Public Health has been steadfast in its commitment to expanding access to immunization services. We have a proud history of working in close collaboration with the Lebanese Pediatric Society in Beirut and the North to strengthening the national immunization calendar and adding new vaccines to it. Back in 2016, we introduced the PCV13 vaccine. Later on in 2022, we added the rotavirus vaccine. And currently, we are working diligently to introduce the HPV vaccine into our national immunization calendar in collaboration with our partners in WHO and UNICEF. The meticulous process entails comprehensive reviews and consultations with esteemed bodies like the National Immunization Technical Advisory Group, the NITAG, chaired by Dr. Bernard Jorbea and co-chaired by Dr. Mariam Majdalani, comprising a diverse pool of multidisciplinary experts in national immunization policies. NITAG provides evidence-based recommendation to the Ministry of Public Health on vaccine preventable diseases, ensuring the safety, efficacy, and alignment with global standards of any new vaccine addition. In addition to NITAG, the ministry consults and collaborates with various stakeholders, including academic bodies and the private sector, whose input play a pivotal role to the introduction and in the introduction of new vaccines and in all matters related to immunization activities. In addition, definitely to the major role that various NGOs like the Cancer Children Center are playing. Once the HPV vaccine is approved for inclusion, it will be distributed free of charge to beneficiaries across more than 310 primary healthcare centers in the country, more than 500 dispensaries, more than 200 private clinics, because we've already initiated a very important collaboration due to the great support of the private sector, headed by His Excellency Professor Jorbea, because we've been into this since years to really enhance the collaboration with the private sector, and this is key. So it will be again, in more than 200 private clinics nationwide, reaching more than 200,000 children annually. So imagine the impact on countries and on the country, on countless lives saved and future secured. Yet none of this can be achieved without upholding the quality and integrity of vaccine. For that, commitment to maintaining the quality and efficacy of vaccine is unwavering. Through partnership with organizations like UNICEF and WHO, we procure high quality, and this is very important to highlight it here, that we procure high quality vaccines that adhere to international standards. Additionally, our cold chain certification ensures that vaccines are stored and handled according to the strictest guidelines, guaranteeing their potency and safety. So we invest considerable effort in capacity building for nurses and physicians and to all the healthcare providers tasked with administering the vaccines. In conclusion, it's crucial for us to collaborate as partners alongside our communities to ensure that every child receives essential vaccination for a healthy future. We must align our efforts under the ministry's guidance, working together efficiently. Let us act now to prevent any regret in the future. So I think the key takeaway from today's discussion is clear: uniting for awareness and action, and leave no child behind. Thank you.
Thank you so much, Dr. Ahmadi. It's my pleasure to introduce Dr. Rafa Burghul, who will be the moderator for our first panel discussion on the theme HPV and Cancer Prevention, Research and Implementation. Dr. Rafa obtained her MD from the University of Balamand in 2010. In 2016, she completed her fellowship in pediatric hematology oncology immunodeficiency at Queen Florida University Children's Hospital, Université Libre de Bruxelles, Belgium. In 2017, she joined a fellowship in sarcomas at the Royal Marsden NHS Foundation Trust in London, UK. Dr. Burghul has been practicing in Lebanon since 2018 as full-time attending with teaching responsibilities. She joined the Children's Cancer Institute as clinical associate in 2021. In 2022, Dr. Burghul was appointed as clinical instructor at AUBMC, Department of Pediatrics and Adolescent Medicine, Division of Hematology Oncology. Please join me in welcoming Dr. Rafa Burghul.
Thank you for your kind introduction. Hello, everyone, and welcome to our HPV conference. Can you hear me? Yes. Okay, so the theme of the first panel is HPV and cancer prevention, research and implementation. Dear guests, allow me to introduce our first speaker for today, Dr. Nada Munshi. Dr. Munshi is the director of the Department of Prevention of Cervical Cancer and HPV. She's the Assistant Deputy Chief for Prevention Health at the Saudi Ministry of Health. Dr. Munshi started a program to vaccinate girls against HPV for the first time in Saudi Arabia as a national school-based program through the MOH in collaboration with the Ministry of Education. The program started in March 2022, where they vaccinated girls in the 7th grade. After that, in September 2022, they started another targeted group for the vaccinations. These were girls between the age of 9 and 18. In 2023 and until now, they have been vaccinating females between the age of 9 and 26 years through the Ministry of Health primary health centers. Dr. Munshi will tell us about the current trends and projections in HPV-related cancers. Please join me, everyone, in welcoming Dr. Munshi.
الو السلام عليكم. السلام عليكم. هلا وسهلا. Do you hear me? Can you hear me?
Yes, we can hear you.
Okay. So thank you so much for having me. I wanted actually to be with you in person, but for an reason I couldn't join you guys. So I think it's better to put it in just a second, because I cannot see the screen of the presentation. Can you share it? Talk to the moderator.
I can't see the presentation yet. Yes, now we can see it. Thank you.
Okay. So is it possibility for the IT or logistics? Can I see it in my screen as well? Virtually? I'm not talking about my
Your presentation can be seen at your computer and here. Can you see it on your computer? There, it's shared. Is there any issue from your side, Dr. Munshi? Are you with us, Dr. Munshi? Can you hear us? Because we can't hear you. All right, we will move to our second speaker until we fix the issue with Dr. Munshi's computer. So our second speaker is Dr. Ibtihal Fathil. She's going to tell us about the cervical cancer screening and early detection. Dr. Fathil is the founder and chairperson of the Eastern Mediterranean Non-Communicable Disease Alliance and chairperson of the MENA Coalition for the HPV Elimination. She previously served as regional advisor on non-communicable diseases at the WHO East Mediterranean Regional Office Division. Dr. Fathil trained as a public health physician. She earned both master's degree and PhD degrees in public health and epidemiology from the London School of Hygiene and Tropical Medicine, University of London. She actively contributes to various international NCD initiatives, serving on advisory groups such as the Lancet Commission on Women and Cancer, the Lancet Commission on Oncological Surgery, and the WHO Civil Society Organization working group on NCD since its establishment in 2017. Dr. Fathil has authored or co-authored numerous papers and commentaries on non-communicable diseases, public health, and cancer policy, including a significant special report on cancer control in the Eastern Mediterranean region. Let's give a warm welcome to Dr. Fathil.
Thank you very much. Thank you. A greeting and good afternoon to everyone, Your Excellencies, dear colleagues, ladies and gentlemen. I'm very honored and grateful for your effort and dedication for addressing this issue related to HPV and cervical cancer, and more importantly, to fostering collaboration between civil society, government, and other sectors. So I'm very honored to be part of this gathering. As you can see on my background, I'm chair of the HPV MENA Coalition. And I will say a few words later about the HPV MENA Coalition and why we are currently working and collaborating with the organization like your organization for addressing the issue of HPV and cervical cancer in our region. So let me start with a few data and figures regarding what is the situation in our region. I'm not sure whether the slide, you have seen my slide or you have shared my slide previously?
Not yet.
Okay, so I will do from my end, and thank you for your patience.
All right, you can see your slides.
All right, thank you very much. So few figures related to cervical cancer, just to remind ourselves, cervical cancer is regarded as the 6th and the 3rd most common cancer in women in the Eastern Mediterranean. Alarmingly, there is 1 woman die every minute in the region from cervical cancer. There is a huge disparity in terms of the prevalence of the cancer in the region. So we find the highest proportion in area of North Africa and also in the Horn of the Africa, Somalia and Djibouti, which constitute the highest prevalence and incidence of cervical cancer in the region. All EMR country, the country when I talk about EMR country, the 22 countries have reported the prevalence of the HPV strain 16 and 18. As we know, these are the oncogenic type of HPV for the causes of 90% causes of women cancer, cervical cancer. And we have the reported based on normal cytology, like it's the prevalence varies between 0.2% in Kuwait and up to 4.8% in Somalia. Noting that cancer registry in our region, especially in the low resources country, is very limited and lacking accurate data. So whatever we report now based on ARC data and WHO data, still we have to consider there is a different maybe when we improve the cancer registry in the region, and also when there will be more data related to HPV incidence. One alarming figures is also related to the mortality. While the prevalence of cervical cancer is still low compared with the rest of the world, but alarmingly is the mortality is much higher than the rest of the world. So we have 0.72 mortality incidence ratio compared with the global figures. Showing here in the slide, the EMR country with the rate representing some of the figure related to the prevalence and the incidence of cervical cancer. And you can see like it varies between 17 and 24 in Somalia and Morocco, and some with country with a low figure like Yemen, Iraq, and some of, say Oman and other country. And again, I repeat the issue of being issue with related to cervical cancer registration and cancer registry in general. And based on the data, like when talking about Lebanon is 3.4. Again, if I go back to the, we're talking here in this panel about HPV prevention. So when we consider prevention, ladies and gentlemen, like we talk about vaccination and screening as the cost-effective tool for cervical cancer and HPV prevention. And we can see the figures here, the performance of the region is lagging behind. So while there is a variation, but still out of the 22 countries, we have currently 7 countries have introduced the HPV vaccination into their routine schedule of vaccination. The Gulf, UAE, KSA, Kuwait, Bahrain, Qatar, in addition to Morocco and Libya. These 3 countries that we incorporated the vaccine into the school-based vaccine program in UAE, KSA, and Bahrain. And they are free available, and some of them free available in public health primary centers like the Kuwait, Qatar, and Morocco. One country, they are having GNV, gender neutral vaccination in Bahrain. And we have many countries still, they are eligible for Gavi vaccination, but still have not introduced the vaccine. So like Sudan, Afghanistan, Somalia, Djibouti, and I know that Lebanon is also eligible. So that will be the discussion by the other panelists and other speakers. And we have a country which is drawback like Libya for the conflict and the situation. What about cervical cancer screening? Cervical cancer screening, as you know, it involves testing for the HPV infection and detection using various methods of detection. And this vary currently in the region. So far, based on the latest data, we have only 9 countries have a national cancer screening program. And however, these cancer screening program, they are not active in terms of invitation for screening. Still, there is a good news and good initiative currently going on in the region related to cervical cancer screening and women's screening, and to list some like UAE women's screening program. Egypt, they have the initiative of the presidential initiative. Tunisia and Morocco, they have a quality assurance structure, which also are responsible or supervise the monitoring and screening program. So we are very optimistic to what's going on, and we are looking for more introduction of screening and vaccination program. We have a very limited data regarding the modality of screening and also the cost of screening. For example, and I'm sure Dr. Nada will mention about that, the cost of pap test currently is fully funded by the government in Saudi Arabia. And for the private sector, it is $50. And I think other countries, similar figures. But this figure is, as you clearly understand, is very low figure compared with the cost of the treatment, which could be vary, if women have a cervical cancer, could be vary between 14,000 to 30,000. And this is the economic and investment argument, which we are currently using for the advocacy for the HPV vaccination as well as the screening. I want to show you also some data related to screening. So WHO country cervical cancer country profile is available on our website as well as the WHO website. And when we're talking about Lebanon as a case, you can see clearly here from the secondary prevention, Lebanon have a national screening program which exists since 2000. This is reported in 2021 by WHO. And the screening is a cytology, the group of women targeted for women from 21 to 65 years. And Lebanon have a protocol as well as they have a referral system in primary care. But in terms of the uptake of the screening, we have 1 in 10 women who have screened for cervical cancer in the last 5 years. So you can see there is a huge limitation in terms of the uptake of the cervical cancer. And I will refer to what's the reason and the challenge. And here, this is slide also, I'm showing some country profile cervical cancer from different countries where we can find in Oman. Still, they don't have a national screening. In Kuwait, they don't have, as well in Jordan, they don't have. And the figures regarding the uptake of the screening could be, the best from like UAE, 3 in 10 women, and most of the country, they reported 1 in 10 women in the last 5 years. So, ladies and gentlemen, you could imagine how much work we need to progress and upscale screening. In terms of research and what is to understand why we have a low rate of cervical cancer screening as well as HPV vaccination. There is a lot of research currently and data regarding the figures and the facts behind low uptake and low rate of screening. And this can vary from different, studies on women's cervical cancer, highlight number of factors, like awareness, how much women educated and know, and their families and the public in general, what they know about the HPV, the disease, the cause, sign and symptom, and also the influence of the relation between the intersection between prevention, screening, and the treatment. So this is an area require and underscore a lot of gaps in this area. The research underscore a lot of gaps. Sociocultural, and a lot have been also
Dr. Fathil, we still have
written about about the myths and belief in our region area, also regarding the access to healthcare, funding constraint and limitation in terms of resources. And the most important one, which we need to work on, is a commitment, a commitment to introduce these effects. So briefly, we have a target to work on, and the target set by WHO, 70% of women have to be screened, eligible women have to be screened, and this is the women between 35 and 45.
Can you hear me, Dr. Fathil? I'm sorry, but we
Yes.
have to finish the presentation. You have 1 minute. Will it be possible?
Yes, so I think our colleague in WHO will talk more and elaborate of WHO strategy. And to strategy, we need more collaboration. We need more work of a different. And this is the area which we have identified clearly to work on. That is, we need to have a commitment, we have training, improve education, we need to work on data and research. So this is a gaps in the area. And here I'm saying we are, as a coalition in our region, working with a coalition of different society, academia, and all are advocating for HPV elimination. And we are working together on doing like what you are doing today, convening, campaign, advocacy, and so on. And I'm very grateful and happy to be with you today and working on this area. So this is a great.
Thank you very much, Dr. Fathil, for your very insightful presentation. We have a minute to take questions from the audience. Aya, do you have questions in the chat box? Yes. Okay.
Hello, everyone. So the following question is all the way from Nepal, from Kishore Kumar Pradnanga, and his question was, which HPV vaccine is more effective?
Were you able to hear us, Dr. Fathil? We were asking which HPV vaccine is most effective in preventing cancer, HPV-caused cancer.
Yeah, so I think I will leave that to other colleague to answer it, because we are promoting HPV vaccination based on the WHO strategy, and that is proved to be effective. And now, the different country, the 7 countries who have introduced HPV vaccine, they have used different protocols, or the protocols of WHO. So some of them, they are doing the 2-dose or 3-dose based on the general the evidence and the guideline. I cannot say which vaccine is more effective than others. I think vaccination, what we are advocating is for vaccination, whether with 2-dose or 1-dose or 3 doses, and on targeting girls from the age of 9 to 13 is the cost-effective intervention.
Thank you. Thank you very much. Thank you again for your presence with us and for your very insightful presentation.
Thank you.
We move to the next speaker. So Dr. Nada Munshi, are you ready with us? Dr.
Yes,
Munshi?
I am ready.
Okay, please go ahead.
So Yeah, I can see the presentation now.
Perfect.
Hello, everybody. I am the director of the Department of Prevention of Cervical Cancer and Human Papillomavirus in the Saudi Ministry of Health. And I am so thankful to give me the opportunity to share my country's experience in the preventing and vaccination of the for the HPV and elimination of cervical cancer. Next. Okay, so as everyone knows, HPV has a lot of number of types, but what we are very concerned of, it's the 12 high-risk cancer-causing types. How spread is HPV? It affects estimation of 75 to 80% of sexually active males and females in their lifetime. And if I want to talk about it in my country, it is the 8th among women female cancers, and in the world is the 4th. And if I want to talk about how many cases that we have, it is 358 female patient of cervical cancer, and 179 die from this cancer because of the late stages of the disease. What happens if HPV infection persists and not the female not vaccinated? It's not even guaranteed it will go by its own, or it will happen and cause cancer. This is why that we're going to talk about vaccination later on in the slides. It's very important to really spread the awareness about the importance of this measure, preventive measure that save lives. Next. Okay. As we all know, there is a lot of cancers, not only HPV related, that will cause worldwide for male and female. If we talk about the estimated 12,700,000 new cancer around the world each year, 5% almost attributable to HPV. And if we talk about out of the 5,800,000 women cancer cases, you have to notice the percentage, how it increased between the developing and developed country, which is 9% of those total amount, of that total amount of the almost 6 million cancers in developed country, but that percentage increased in the developing countries to be 14%. Next. Okay. When we can develop this cancer, it takes years and decades to get this cancer to be manifested. And there is no way we know who will develop it and who won't. Next. So the disease burden around the world, I like this figure because I put many cancers caused by HPV. As you can see, the one in the middle and the globe shadow is for both sexes, the cancers for both sexes, and the benign, of course, for the male, and the cervical and cervical dysplasia and vulvovaginal cancers is the, sorry, yeah, it's the one for female. I want you to focus on the cervical cancer. Can you see it's almost 600,000 for female around the world, and it's not a very something we can just move with, like, oh my God, it's a little number. It is huge, and a lot of people and female could lose their life. and the other like oropharyngeal cancer, 92,887, and respiratory papillomatosis, and anal and genital warts. Oh, this is the critical, again, another disease caused by HPV, which is a huge number of millions of people have it every year, 32 million. Next. Okay. It's really associated not only with certain cancer and diseases, as well as we said, genital warts, anal cancer, vaginal cancer, and vaginal intraepithelial neoplasia, vulvar, cervical adenocarcinoma, cervical cancer, CIN 1 and 2 and 3. Can you please go to the next slide? Okay, so I like this figure because give you 3 tracks up to 20 years. What happened if we have initial HPV infection? So it go up to 20 years, the first, if you can see the first track to develop cervical cancer, or go to CIN2 1 and then clear by its own, or it can go to CIN1 and continue infection to CIN2 and 3 till the cervical cancer. And genital warts and cervical dysplasia, as I told you, again, it can go both ways, clear by its own or to develop cervical cancer. Next. Estimated percentage of cancers attributable to HPV. If I get the HPV infection, what is the percentage to get a specific or a certain cancer? If you can see in cervical cancer case, it's almost 100%. It's the main cause. The HPV, the human papillomavirus is the main cause. This is why, guys, it's so important to get vaccinated and spread the awareness among each of our community in each country, in Middle East or in the world in general, because you have to tell them this is used to save your life eventually in life. You can see anal, vaginal, vulvar, the percentage decrease as we go.
Dr.
Like the anal 88%, the vaginal 74%, and the vulvar 30%. Okay, next. Okay, so what are the measures that we can take to prevent a certain cancer of the cancer that I mentioned? In the case of cervical cancer and cervical precancer, it's absolutely with no question, you have to do both measures, which is routine screening and vaccinations. If you can see other cancers and precancers, it could be almost the vaccination will be very good measure to prevent them. Okay, next.
Thank you. We're running out of time, Dr. Munshi.
Okay. So I'll just go to the, you can see in the slides that decreases with the, even the genital warts decreases with the, next please, with the vaccination. You can see the percentage, the one in the green boxes. I'm just going to go 1%, 76%. It will be prevention when we follow them for 5 to 8 years in the case of genital warts. Next. Okay, we are not alone in Saudi Arabia. More than 140 plus countries have this vaccination program. Next. Okay, this is the main thing that I'm going to mention. In March 2022, Saudi Arabia launched one of the largest HPV vaccination programs in the Middle East and North Africa region. We vaccinated girls from 9 to 13 years old, 7th grade, and we do it till now, till today. Next. Okay, till now we have coverage rate of more than 70%. We are very proud of this establishment and achievement of this vaccination. And the target group was from 9 to 18, and now is from 9 to 26 through the PHC's primary healthcare centers. So this is why it's so important to increase the age groups. Next.
Thank you, Dr. Munshi, for sharing with us your expertise and knowledge about this very important topic. We're going to
Thank you so much for having me. Thank you so much.
Very much. So we have questions for Dr. Munshi.
Yes. So we have one question from Vince Philip. How do men get an HPV infection?
How to men? It's the old thing in the world in history. So it doesn't matter who get it first, female or female, male, sorry, or female. Sexual route is the main or the most known route of transmission of HPV. So absolutely, they get it through sex mainly.
Dr. Munshi, I have a question for you. Are you planning to include males in your program soon?
Inshallah, this is one of our main future vision. Yeah, to make it for both sexes, absolutely neutral.
Thank you very much for your time and for your presentation. We will move to the third topic for today. So the third presentation is about the role and importance of awareness on HPV vaccinations and preventing HPV-related cancers. Our speaker is Ms. Sandra Khouri. Ms. Khouri is the Managing Director for MSD in the Levant and North Africa regions. She is known for her inspiring and transformational leadership, for successfully leading businesses in the most challenging and complex markets. Ms. Sandra has strong experience in the areas of primary care, vaccines, and oncology. Since joining MSD, she has worked in multiple countries, including the US, France, and Switzerland. In her current role, Ms. Khouri has launched a compelling vision and agile ways of working that resulted in a transformation of the healthcare system through partnerships. Sandra holds a degree in pharmacy from the Lebanese American University and plays an active role in the pharma industry groups across the Levant and North African cluster. Welcome, Ms. Sandra.
Thank you very much. So good afternoon, and thank you for the opportunity to be here today. So at MSD, our legacy started over 130 years ago. And our focus has always been science. So we follow the science, and our research is centered currently in three major areas. The first is oncology, where we aim on creating and inventing a world where cancer can not just be treated, but cured. The second is vaccines, and it's a legacy that started in 1895. We all know the value of vaccines. Vaccination is the most cost-effective public health intervention after clean water. And the third is in the area of hospital, specialty, and chronic care, where we have a legacy that we aim to build upon in order to develop the innovations of tomorrow. Next. Great. So we've heard a lot today about HPV-related cancers and diseases, and I'm certainly not going to repeat what we have heard. But one main message is that HPV causes more than 6 types of cancers. Good news, they can be preventable. Now, there are certain types of cancers that are almost 100% related to HPV, like cervical or anal, but also 70% of oropharyngeal cancers are related to HPV. I'm going to invite you, please, to look at the right side of the chart, and we will see that data from the US shows that the number of back of the throat cancers in men are even more than the cervical cancer cases in women, which means that we need to intensify awareness among girls and boys, women and men, as we drive HPV-related cancers prevention. So prevention starts with awareness, with education, and definitely with vaccination. There is compelling data that came out from Switzerland and China saying and suggesting that school-based health education played an effective role in increasing the awareness of HPV and of HPV vaccination. It increased vaccination rates and enabled them to get closer to a world free of HPV-related cancers. Besides awareness, vaccination works as well. If we go to the Nordic countries, for example, Sweden and Norway, so those countries have integrated HPV vaccination as part of the child's routine immunization. Sweden took it a step ahead, and it is today most likely the first country that is going to achieve cervical cancer elimination by 2027, which is in the next 3 years. Even data from the UK and most recently from Scotland have also showed that there were no cases of cervical cancer reported in girls, in women, excuse me, that were vaccinated by the age of 12 and 13. And finally, I think we heard it from Dr. Sulh this morning, the American Cancer Society issued its report recently suggesting that in this report, they looked at the state of cancer in the world, but more particularly in the US. And they shared that over the last decade, there is a striking 65% reduction in the incidence of cervical cancer because of vaccination. So we also heard this morning from Dr. Ibtihal and Dr. Munshi that the Middle East is joining efforts in cervical cancer elimination. So I'm not going to go through this. Maybe we will jump immediately to the state in Lebanon. We all have a critical role to play. And in Lebanon, there is so much power in the public-private partnership. So first, by combining resources, by combining expertise, we can certainly address in a very effective way the healthcare challenges that we face. Not only that, but also by sharing scientific knowledge and best practice experience, we can definitely achieve sustainable developmental goals, improve access and healthcare outcomes in the future. And finally, by partnering with all the key pillars in societies, if it's healthcare, whether it's healthcare professionals, whether it's healthcare professionals, scientific societies, health authorities, patient organizations, scientific bodies, medical institutions, I think we can make significant impact and a meaningful progress towards achieving a world free of HPV-related cancers and diseases. As a company, today we are supporting medical institutions and university medical centers in raising awareness around HPV. We are also partnering with social media influencers so they spread the word in their own communities around HPV awareness. And third, we are collaborating with scientific societies and organizations like CCCL in order to raise awareness around HPV. So our role definitely does not end here. And as a company, our commitment to society stands in 4 key areas. The first is a commitment to corporate social responsibility. So we engage in community service work to give back to the communities that we serve. The second is MSD for Mothers, which is a global initiative aimed to improve maternal health because no woman must die giving birth. The third is another global initiative, which is the MSD Health Equity Catalyst Fund, aiming to improve equitable health outcomes in the communities where we serve. And I'm very proud to share that one of the recipients of those grants is actually CCCL. And last but not least is our commitment to cancer care, whether it's through driving awareness, testing, diagnosis, and enabling treatment and prevention of the most difficult types of cancers. So thank you.
Thank you very much, Ms. Sandra, for beautifully presenting the importance of HPV vaccination. Thank you very much. Do you have questions for Ms. Khouri? Aya, do you have a question there? No. Okay. So I think, thank you very much. We will move to the last speaker. So our final presentation for this panel is, it's an honor actually, and a great pleasure for me to introduce our esteemed speaker, who's a true leader in the field of pediatric neuro-oncology. Our speaker spent almost his entire career on treating children with brain tumors. He brought a wealth of knowledge, expertise, and major contribution in the field of pediatric neuro-oncology. But today, he will be sharing his insights on the role of public policy in HPV prevention. Our dear speaker is Dr. Eric Buffet. Dr. Buffet is Emeritus Professor of Pediatrics at the University of Toronto. Throughout his career, he practiced in France, UK, and Canada. He was head of the neuro-oncology program at the Hospital for Sick Children in Toronto from the year 2000 until 2022. His research interests are in the area of clinical trials in children with brain tumors and implementation of neuro-oncology programs in countries with limited resources. Dr. Buffet is author or co-author of over 600 peer-reviewed manuscripts and numerous book chapters. He was also president of the International Society of Pediatric Oncology between 2016 and 19, and is currently a member of the Union for the International Cancer Control Board of Directors. Please, everyone, welcome Dr. Buffet. We are very pleased to have you with us today.
Thank you. Thank you very much for this kind introduction. So I'm pediatric neuro-oncologist, but I speak more as a UICC person and trying to figure out what we can do today that will help children when they become adult tomorrow. Tobacco prevention, HPV prevention are two examples that are absolutely critical to start as early as possible. Next slide. So you heard about, the background and HPV and how it can really be prevented by prophylactic vaccine, but it will not work if you don't put together the screening program. And we heard about the combination of two that are critical to eradicate the disease, but also the fact that, the majority of cervical cancers still occur in developing countries. So we need to focus on this and try to make sure that we implement this program, not only in high-income countries, but also in countries with limited resources. Next one. So here you see a slide that gives you some idea of how fast things went, in fact, because between the first meeting on HPV to the approval of the first vaccine, it was less than 20 years, so which is absolutely phenomenal. And the Nobel Prize to Dr. Hausen, who was one of the leaders of this research, identification of HPV as the cause of cervical cancer and many other cancers, and also it triggered a lot of research into the vaccine. So on the next slide. So the effort of the WHO has to be applauded because there was really a development of a global strategy to accelerate the elimination of cervical cancer with an ambitious aim to vaccinate nearly 90% of the girls by the age of 15, to screen also young women and to make sure that we have the bridge here between the screening and the vaccination, knowing that we have now data that suggests that if you vaccinate, and we heard this from the previous speaker, you can eradicate, and this has been seen already in some Nordic countries, you can eradicate. There is no more cervical cancer in the population of girls who have been vaccinated during the last decade. Next slide. And we have now a number of countries that have joined the WHO classification. Now, one thing is about the policy and what is the impact of policy. And there is this superb publication from Norway that say in 2009, there was already a discussion to implement the vaccination and to implement the screening. But there were debate, and people, and the politician, in fact, had a debate about whether it was really true that the vaccine was preventing the cancer, and they wanted to wait for the evidence and the demonstration. And as a result, there was a delay in implementation by 6 years. And this delay, according to this publication, has caused certainly, or has potentially caused, 1,000 more deaths associated with cervical cancer in the country, and has delayed the elimination of cervical cancer and HPV-related cancer by 4 years, just by delaying the implementation. So it's important that one of the players is first the government and decisions of the government. Next slide. Now, even the government agree. You can see, and this is in French because I found this document in French, that the government approves, but you have also to go to the public and to speak to them. And in France, only 45% of girls are vaccinated and 6% of the boy. And despite the fact that the vaccine is free and that the government has approved. So next slide. So what can you do? And there are very good examples in Africa where you see, according to the effort of the government, you have different scores. Prevention, which is a vaccination, secondary prevention, which is a screening, and tertiary prevention, which is a treatment of cancer. And you can see that some countries have already a very high score, like South Africa. Next slide. And when you look by detail, you can see that countries like Kenya have already implemented a vaccination program, which is extremely successful. And the same also in Rwanda, where there is a very, very effective vaccination program. So it's not about the wealth or the resources of the country. It is about what the government want to do and how they want to implement this vaccination program. Next slide. And so when we look at Lebanon, I found two papers that were very, very important and very interesting, in fact, because even if there is a support and a willingness to implement, it's very recent, and this is not part of the vaccination program. Lebanon does not include HPV in the national routine vaccination program, but there are doctors who are proposing the vaccine, particularly when they deal with female patients, when the patients are accompanied by their mother, and when they declare some sexual activity, and when they have what we call a non-conservative background. So I don't know what a non-conservative background, but it's also about education. And next slide is even more illustrative because it's about a survey that has been done among students and medical students. Next slide. That show that there is a need to educate the doctor. And in medical students, you see that there were questions that were raised and who should be vaccinated, that they know about this. But is the vaccine expensive? Very few people know about the cost. Does the vaccine have side effects? Yes. And if they mention the side effect, you can see that some people say hair loss, some people say fever, nausea. And then the last question was about, are you vaccinated yourself against HPV? Medical students who should be aware of this, only 17%. So really there is a problem of knowledge and adoption of the policy. Next one. And this is also about the myth and what people know about. And this is a problem that I mentioned in France. HPV vaccine sometimes create a myth. Next slide. And this was a survey that was looking at the myth. Some people say it's unnecessary. You don't need the vaccination. Nobody gets cervical cancer. And it can cause some side effect. And it can also cause you know, some information about this is completely absurd. So you have a list here of myths that have been collected on Twitter, in fact, and among the messages that were collected in this survey, in fact, they were between different countries, there were nearly 20% of the messages that were about the myth and about wrong idea regarding HPV vaccine. Next slide. Now, when we look at the world in 2006 and in 2021, we can see that there has been a tremendous progress in the vaccination program. Look at this. So South America has a vaccination program, and even Africa. But there is still a big place here that is a problem. Next slide. And when you look at this, China is one country that has the highest rate of cervical cancer. And despite this, only less than 1% of the girls are vaccinated in China. There are 15 cities that have a pilot study, but one of the things in China, you have to pay for the vaccine. And the fact that you have to pay for the vaccine is going to discourage 90% of the people in China. And really, one of the policy is to implement a vaccination program, but one is to make it free for access. And this is one of the issues that we observe in some countries that want to implement vaccinations. If you have to pay for it, nobody will go for it. And the family prefer to just say, it's not going to happen to me. And this is really one of the policy which is critical. And when you go around the country that have failed the vaccination program, it's essentially because a lack of organization and the cost of the vaccine. And so far, next slide, the most successful program have been
1 minute.
Yeah, the program that have integrated the vaccination into school program, and in Canada, in UK, in Australia, the vaccination of girls is above 85%. And this has been through this school program that are very, very highly effective. But in addition, the buy-in from the medical community is critical if you want to implement such programs. I will finish here, and I thank you for your attention.
Thank you very much for this amazing presentation. Do you have questions for Dr. Buffet? So, and anyone in the audience? No? So thank you very much, Dr. Buffet, for your time, for your presentation, and for being with us again today. I think we'll see you tomorrow in the tumor board. Thank you again. Thank you, everyone, for attending. Thank you.
I would like to extend a sincere thank you to our moderator, Dr. Rafa Burghul, and all our esteemed panelists. As we conclude our first panel discussion, we invite you to take a 10-minute networking break. Please ensure to return on time for the next panel. Thank you and enjoy the networking. It is my pleasure to introduce Ms. Rosalia Nassour, who will serve as the moderator for our second panel discussion on the theme HPV vaccination challenges and innovations. Rosalia Nassour is the Public Relations and External Affairs Coordinator at the Children's Cancer Center of Lebanon. Rosalia has been a member of CCCL from 2019. She started her career at the center by being in the Patients Relations Department, where she worked closely with the CCCL's main stakeholders, the parents of children with cancer, before moving to the Public Relations and External Affairs Department. Since then, Rosalia led on the CCCL HPV awareness program with schools and universities. Please join me in welcoming Ms. Rosalia Nassour.
Hello, everyone. Thank you for attending our second panel. In this panel, we will dive in more with the stereotypes and issues derived from the HPV vaccination, some success stories, the landscape of HPV and its consequences in our region, and how important is HPV vaccine for both genders. First, I would like to welcome and introduce all of our speakers who are in person with me here to the panel. First, I'd like to introduce Dr. Giuseppe Traiusi. Technical Officer in WHO's Regional Office for the Eastern Mediterranean. Dr. Giuseppe, who will be joining us virtually, he is a medical professional specialized in public health with a focus on non-communicable diseases, including cancer. His current role as a technical officer at the WHO Eastern Mediterranean Regional Office involves leading the WHO Global Initiative for Childhood Cancer, as well as rolling out the WHO Global Breast Cancer Initiative and the WHO Global Cervical Cancer Elimination Strategy. In his role, Dr. Giuseppe provides support to member states planning, developing, implementing, and following up on national strategies for the prevention and control of NCDs, including cancer. Previously, Dr. Giuseppe was part of the United Nations Interagency Task Force, where he contributed to support a coherent UN-wide response for the prevention and control of NCDs, including by adopting a whole-of-government and whole-of-society approach at the national level. He holds a Doctor of Medicine from Italy and a Master of Public Health from Columbia University, United States. Throughout his career, Giuseppe has been committed to developing and implementing health programs and providing technical guidance in his field. Second, I would like to welcome Dr. Bernard Jebaa, please, with me. Yes. Dr. Bernard, head of the NITAC committee at the Lebanese Ministry of Public Health, professor of pediatrics in St. Joseph University in Beirut, former member of the Faculty of Medicine Council, Faculty of Medicine USG, former chairperson of the Pediatric Department, Faculty of Medicine USG, chair of the NITAG National Immunization Technical Advisory Group, MOH, founding member and vice president of the Lebanese Expanded Program of Immunization Technical Committee, EPI-MOPH, vice president of the National Certification Committee, NCC-MOPH, past president of the Lebanese Pediatric Society 2015-2017, and former chair of the Scientific Committee, Lebanese Order of Physicians 2009-2011 and 2019 to 2022. Founding director of the Child Protection Unit, past president of the International Society for the Prevention of Child Abuse and Neglect, founding member and treasurer of the Arab Society for the Prevention of Violence Against Children. Second, I'd like to welcome Mrs. Hana Shawar al-Shaib, CCCL General Manager and UIC Board Member to the stage. Mrs. Hana, CCCL's General Manager and member of the Board of Directors at the Union for International Cancer Control, UICC, from 2020 till 2024, a passionate leader and advocate for childhood cancer. She joined the Children's Cancer Center 20 years ago when she worked tirelessly with the Board of Trustees to make it a leading center in providing free treatment for children with cancer without discrimination and without any cost on the parents. Mrs. Shaib worked hard to ensure that all children with cancer in Lebanon and the region receive treatment, psychological support, and social support regardless of their backgrounds and financial means, despite all the challenges that Lebanon has faced and continues to face. Lastly, I'd like to welcome Dr. Bassel Bashir, urologist at UBMC. Dr. Bassel, please welcome. Dr. Bassel Bashir joined the American University of Beirut Medical Center as an assistant professor of urology in January 2016 after completing a 2-year research fellowship in the biology and therapy of urothelial carcinoma at McGill University. Then acquired a 2-year clinical fellowship in male infertility and male reproductive medicine at the University of Toronto Mount Sinai Hospital. Since joining the Division of Urology, Dr. Bashir has greatly enhanced the male infertility service at AUBMC. He works very closely with his colleagues in reproductive endocrinology and infertility to offer infertile couples the best chance at conception. A round of applause for our speakers. So first, we're going to start with the presentations of all our speakers, followed by a Q&A and discussion with our panelists. So first, we have, for topic 1, the current landscape of HPV vaccination program in the Eastern Mediterranean region. We're going to start with Dr. Giuseppe Triozzi, please.
Okay, good afternoon, everyone. I hope you can hear me. You can hear me well? Yes? Probably not. Can you hear me? Hello?
Yes, we can hear you.
Oh, okay, great. Nobody was speaking. Okay, thank you so much for the introduction. Gives me more time for the presentation. I will go fast because most of the information was already shared in previous presentations, in the previous panels. So I think I will just focus on HPV vaccination and what other countries are doing currently. So next slide, please. Okay, we already talked about that. This is, next slide, please. This is the rationale why WHO has launched, next slide, please, has launched an initiative on cervical cancer, on a cancer. We don't usually support, encourage vertical programs, but this is really an opportunity in a lifetime. And for the first time in history, we can eliminate a cancer. Next slide, please. So the strategy is around elimination of a cervical cancer, which for the people who are in global health for even longer than me might sound new, because usually elimination is dedicated to infectious diseases, and for the first time we can say that we can eliminate a non-communicable disease, a cancer, and this can be done by 2120, around 100 years from now, if we get to an incidence of less than 4 cases per 100,000 women. To get to this goal, by 2030, we need to vaccinate 90% of the girls, screen 70% of women, and treat 90% of precancerous lesions. Just want to, next slide, please. Just want to focus on one thing. If we want to reach the, can you click play? There is an animation. If we want to reach, can you please click? It's not play, just yes, okay. If we want to reach the goal by 2120, it's very important that we don't focus only on one of the 3 pillars of the global initiative, but on all the 3 of them together. And as you can see by this graph, this is a projection, a modeled projection, showing that in the blue line, vaccinating only will contribute to achieving the result much slower than vaccinating, screening, and treating altogether. I really want to stress this point because vaccination seems a low-hanging fruit, but we need to do the extra effort and also implement the strategy in full. Next slide, please. Next, yes. So the regional situation, we already talked about that. One of the most common cancers in women, but not only that, it affects women in their most productive years, and this hints to the economic argument that Dr. Iptial was mentioning a while ago. The economic argument saying not only countries and governments are losing money because they need to treat a disease that is preventable in terms of direct healthcare costs, but we are also losing women that can contribute socially and economically to the output of our nation. So there is also a component of indirect costs that it's usually overlooked by countries, and there is a WHO EMRO publication, an investment case that will be published and launched very soon, that shows exactly what I'm talking about. And just to give you a very quick teaser, 99% of the cost of cervical cancer is completely overlooked by countries. It's not direct healthcare cost, but it's indirect healthcare cost. Anyways, we talked about mortality to incidence ratio, 0.65 or 0.70, depending on what data you're using. It's definitely underestimated. not only because of weakness of cancer registration in the region, but also because there are some additional considerations that sometimes make a diagnosis of cervical cancer difficult to tell and to record. The incidence will be doubled by 2040, and this is just through increase of the population in the region. We are not even talking about changing in behaviors, changing in distribution of risk factors, just by maintaining the status quo and by looking at the population increasing, there will be a double incidence of cervical cancer by 2040. Next slide, please. So this is what I was mentioning before. In 2020, cervical cancer costed the region $2 billion. In 2040, will cost $178 billion, with dramatic impact for individuals and families. Next slide, please. And the situation in Lebanon is the one that you're seeing. The mortality to incidence ratio is again dramatically high. It means that almost 2 out of 3 women with a diagnosis of cervical cancer die because of shortcomings at the level of health service delivery. Next slide, please. So basically, we are not doing enough to treat these women. The interventions that are being implemented in the region, we already said that vaccination is being implemented in national immunization plans in Morocco, Libya, Saudi Arabia, UAE, Bahrain, Kuwait, and Qatar. Pakistan, Djibouti, and Lebanon clearly are interested. I should say also Oman and Tunisia. We will see it in some of the next slides. Excuse me, can you go back? Okay, thank you. When it comes to screening and treatment, though, this is really a really bad situation. Only 7 countries are doing some screening, but it's really opportunistic. It's not systematic. And treatment, especially in the low and middle income countries in the region, is not adequate. Next slide, please. So based on the 3 pillars of the global strategy and these special considerations on our region, in 2023, in January, the WHO Regional Office for the Eastern Mediterranean released a regional cervical cancer elimination strategy. So as you can see, the action pillars 1, 2, and 3 are pretty much the same as the global elimination strategy. But then we added 2 additional actions on health system strengthening and on communication, advocacy, and social mobilization to make sure that cross-cutting initiatives also look over cervical cancer elimination, and that cervical cancer elimination is integrated into broader efforts for health system strengthening, and that we reach through communication also communities and individuals even in remote regions. Next slide, please.
Excuse me, doctor, we still have 1 minute.
Okay, so next slide. Even better. Okay. So the HPV vaccine, I just wanted to highlight that based on the latest SAGE recommendations, we don't need 2 doses anymore. We only need 1 dose. 1 dose is as effective as 2 doses, which makes implementation in low and middle income countries even easier because you have an opportunity to cut costs by half. Next slide, please. The vaccine has an excellent safety profile. There have been more than 500 million doses used globally from many years. So there's really no argument against the vaccine in terms of public health. Next slide, please. This is the summary of SAGE recommendations. Most people ask about vaccination of boys and older age targets. As long as the supply of drugs is, of vaccines is ensured, you can also vaccinate populations outside of the target one. Next slide, please. Actually, two more. I just want to show you the regional situation in terms of vaccination. As I said, the 6 countries are Morocco, Libya, UAE, Saudi, Qatar, and Bahrain and Kuwait. Oman is joining the other GCC Gulf countries in 2024, and Pakistan and Afghanistan have also expressed interest in implementing the vaccination. Next slide, please. Yes, next, please. Okay, thank you. So these are the challenges. I just want to highlight the fact that some religious leaders and leaders at the community level have been quite resistant to the introduction of vaccinations in some of the countries in the region because it's a sexually transmitted disease, and in a very conservative region such the EMR, acceptability and anti-vaccine movement for a sexually transmitted disease are very relevant. So we need to counter that as strong as we can. Other barriers, are due to the economic barriers in terms of cost effectiveness. It's important that we, as WHO, we advise governments how to divide the pie in terms of programs that can be implemented. And then conflict areas, of course, have additional challenges. Next slide, please.
Doctor, I'd have to cut you, sorry, excuse me, because you have to have time for the other panels.
Okay, I have only 2 slides left, so if I can.
Okay, if you can just wrap it up quickly, please.
So I mean, I think these presentations will be shared with the audience, so you are free to look at what UAE and next slide, Saudi Arabia, and next slide, even Morocco have done in terms of implementation of these programs. Last slide. Yes, just wanted to make sure that I mentioned these in the way forward. Gavi, the Global Alliance for Vaccines, has expanded the support strategy also to include middle-income countries. And Lebanon is, in fact, eligible for Gavi support for the introduction of the vaccine. So this is a very important window, opportunity that we, as Lebanon, is important to take advantage of. And as WHO regional and country offices, of course, we are here to support that. Sorry for taking longer than expected. Thank you very much,
Thank
everyone.
you so much. Thank you, Doctor. We'll keep the Q&A for the end of the discussions and the presentations. Next, we have Dr. Bernard Girbao. He will be talking about addressing barriers to HPV vaccination uptake. Please welcome. Yes.
Hi, it's a pleasure to be here. So what makes a conference successful? You have the IT, you have the speakers, you have the organizers, the hosts, the good food outside, people interested, someone who will take the notes and carry the legacy on so that you can translate the speeches and the data into programs. So if you don't have the IT, no one can listen to the speakers. So my keyword is together. And why? Because together it works. And if not together, it does not work. This is how vaccines also work or do not work. And I see that the keywords of other speakers were congruent. Your keyword was unite. I think someone had the keyword of partnership. We had keywords of collaboration, communication, integration, inclusiveness, to protect. So the picture of a pediatrician giving a shot in the arm or the leg of a child makes it very personal. Yes, it is a P2P procedure, but the whole thing needs a lot more to work. And cold chain, for example, safety, efficacy of vaccines, cost effectiveness, priorities. We'll talk a little bit about all that. And I'm here in my position of NITAG chair. I'll try to stick to this position. But let me tell you that in the NITAG, we are appointed by the minister, but we are completely independent. The minister does not tell us what to do. EPI does not tell us what to do. We're independent experts. We have to disclose any conflict of interest, and we vote. So this is how the process goes. And I will tell you more about the procedure itself later on. But I need you to learn more about how NITAG works. We believe that SDG 3 is an important component of Agenda 2030. And our approach is on vaccination about a child rights and health sound approach. So it's bringing together WHO and United Nations agencies so that we can make the SDGs work, and especially in vaccination. You just tell me how to do it, or you do it? Okay. I'm sorry, I put in, can you remove this, or should I? Okay, that's it. So the Lebanese context, you know it. The data, you know it. I need to tell you that we go through a SWOT approach so that we can identify what are the strengths and weaknesses and what are the threats, the challenges, and the opportunities forward. And we discuss in the NITAG how we can do the implementation plan. We don't do the implementation, EPI does that, but we are part of the project. And I would like to also highlight something very important at the Ministry of Health. There are different bodies in the Ministry of Health. There is the NITAG, the NCC, the EPI, the SUMO. Those are departments that work together. If they don't work together, we cannot provide an implementable program. And it has been recognized by East Mediterranean region, WHO, as one of the best child protection examples. How in this ministry, people work together. And you need some kind of mindset of common good in order to take this forward, because in the NITAG, we're all volunteers. So we beneficiate from other experiences in the region or also global momentums. We know that we have a frame. Within this frame, we try to work, whether it is the WHO 2030 plan or the 2023 plan, and also the IA 2030. Those are global approaches and global frames that we use in order to try to promote Lebanon as a country where we need to provide vaccines for children. And there is something that is very delicate to know. It's that we have worked for years in order to make Lebanon a Gavi eligible country. It needed the commitment of a minister, of Dr. Abiad, and also it needed the work, the seeding work for 2 years in order to be able to make Lebanon a low middle income country, but also Gavi eligible. And it's very important also to know that the challenges are not always financial. Sometimes they are societal, and we saw a red flag here. One of the red flag is sexually transmitted diseases. So obviously, it's a way to do segregation and discrimination among the population. The next one, please. So I would like just to show you a slide on the Lebanon program. We have succeeded in having 11 antigens in our national immunization program. But we went through many challenges, and at some point of time, we were able to have 98% of children in Lebanon that were vaccinated with mandatory vaccinations. We went down to less than 50% for many reasons that I'm not going to address here, but we identified those reasons, and now we are getting back to business. We're not the only country who faced those issues. Other countries also faced those issues, but we need to know that we are a vulnerable country. For example, who among you has seen cholera? I haven't seen cholera in 40 years. So we've seen cholera last year, and we were forced to work very quickly, and I would like to say very successfully in addressing this issue. And we were also, in spite of all the challenges that you know, to keep Lebanon polio-free. Why is that? Because we work together. Next one. So none of you, I think, has seen smallpox. Has anyone seen smallpox? Okay, so we have the culture of seeding a tree, and we see the tree, but it's not there yet. It's going to protect me. It's going to protect the next generation. This is how the culture of vaccination works. And if you don't integrate this in your mindset, you cannot build up the momentum to prevent something. And it's very important. The primary prevention is very important. Next one, many diseases that you see here, you don't see anymore. Some of them, alas, you can still see in Lebanon, but it's very important to work on something that you don't see anymore. We haven't seen a case of indigenous wild polio since more than 18 years, but we still are very strong in doing the polio vaccination. Next one. So we see that the vaccination is going down also during COVID because of the many reasons that brought vaccination down in many countries. The next one. And one of the vaccines that is most affected by when you go down on the vaccination is the HPV vaccination. We were very successful in introducing in 2010 the HPV vaccine. There was a very good momentum. It was endorsed by the Lebanese Order of Physicians, and we had guidelines on that, and those guidelines have been reviewed and updated recently. So now we are in the business of appointing a working group in the NITAG in order to build up the evidence so that we can present recommendation to the EPI and to the Minister of Health. Next one. So we have many challenges. Of course, one of them is financial. The other one are security issues. I would like to highlight one of the last slides of the EMR representative. It is also the case of Lebanon. We had shortages, overstretched primary health care, the blast, healthcare workers leaving Lebanon. So yes, the challenges are still there. It's not out yet. We're still in the mid of the challenges. This is why we need to think with science and intelligence. The next one. So if I want to highlight some of the ideas in order to reverse the fall of child vaccination rate, some of them address the policies, and you can see them here. Some of them address the society, and some of them address programs and logistics. It's not enough to make a vaccine free and accessible. You need to convince people. So one of the studies we're talking about conservative society, another poison in the mind of stakeholders and of families. So if there is no sex, you don't need the vaccine. If you're conservative, you don't need the vaccine. So those are poisons that we need to be aware of when you talk about the vaccine. Of course, we will add to this the non-availability of the vaccine and the high price of the vaccine. But even in countries where this vaccine is available for free, sometimes children don't get it. And we have to address the societal, the norms and values elements so that we can talk to people and talk about cancer and early prevention. Why in the CCCL we talk about cancer that occurs mainly in adults, beside the oropharyngeal cancer? Why? Because this is where the seeding is. You start your program with children so that you can protect them later on. Why do you vaccinate adolescents? Because this is when you have the best time, the best window of opportunity to do the vaccine. It's not a question of when is the first sexual contact or not. It's a question of what is the evidence-based window, scientific window to do the vaccine. Next one.
Excuse me, Doctor.
Yes,
can we
I'm
wrap up
almost
a bit?
done.
Okay.
I'm almost done. Thank you very much. So we have a program for 3 to 5 years. We have the tools in order to build up the recommendation. Next one. Physicians need to do much more. You know that patients in OBGYN, in pediatrics, look up at the healthcare provider. What you tell them and what you tell them that you're doing to your own family has a lot of influence on their own decision-making. So confidence, complacency and perception, it can lead to prejudice if you don't work it correctly. The convenience, the stigmatization, girls versus boys, the communication, the contradiction, the misconception, and the context, the rumors, the myths. The first cause of death after HPV vaccine is road traffic injuries. So, and also other C's like the COVID and the cohesive anti-vaccine groups. You know, the vaccine hesitancy is among the 10 health threats by WHO in the coming 10 years. So we really need to address them very seriously. Next one. Next one. Next one. So the systematic ETR process goes into the question that we need to ask. The next one. Then the criteria to build up our evidence. Next one. Then how we can enunciate the evidence. Next one. And lastly, how we do the recommendation. This is the procedure that we follow up, the evidence to recommendation process. And there are many domains between the problem, the benefits, the values and preferences, the use of resources, the equity, including the stigma, the acceptability by stakeholders and population, and the feasibility. So this is my last slide. I thank you for listening. I'm sorry if it was a little bit crowded.
Thank you so much. Thank you, Dr. Bernard. Third, we have Mrs. Hannah Shahar Shaib, please. Mrs. Hannah will talk about the success stories of the HPV vaccination campaigns and in specific CCL's HPV vaccination campaign.
Good afternoon, everyone, and thank you all for attending. I promise I'm gonna be quick so that because I know it's the end of the, but it's important. The topic today is very important, and it is very important to highlight the role of the Children Cancer Center in protecting our children, our patients. Before we start how the HPV program started at the Children Cancer Center, I'd like to take a moment to just explain about the CCCL. And for those who are not very aware of our mission, the CCCL has started in 2002, in April 2002, where the center was a pioneer in the region at the American University of Beirut and in close collaboration with St. Jude Children's Research Hospital in Memphis, Tennessee. What was unique about the center is that it provided the services that no one at that time provided and helped the Ministry of Public Health in offering the treatment to everyone. So at the Children Cancer Center, we cover the whole treatment for the whole cost of treatment for our sick patients. So every child who comes to the center, and even if they have guarantors, we cover the difference. And in collaboration with the Ministry of Public Health and the other public guarantors, we and the AUBMC, we had like a formula of how to provide the best services and how each one can provide their share in this coverage of treatment. So the next slide, please. It is about the center, about a glance at CCL. And also, this is what we cover. We treat children who are newborns till the age of 18 years. And for that, in order to be able to cover the treatment cost, we depend on our fundraising. So for the past 22 years, because last week, it was the center's anniversary, 22nd anniversary. We have been able to raise more than, on average, around $15 million every year in order for us to provide the treatment and to have the center as a center of excellence. In short, the figures here show that we have provided more than treatment for more than 5,000 children and more than 6,000 medical consultation. Currently, we have all in all around 500 current active patients at AUBMC and at other partner hospitals. And this adds up so that we are able to treat around 50% of the children who are diagnosed with cancer in Lebanon. As we mentioned, our mission is to provide access to the treatment. However, as well, it is to raise awareness and to provide the excellence in psychosocial services. This helps the children in order for them to survive. In the next slide, we haven't stopped there. We have intensified our efforts since 2016 to become members in international institutions. So the Children Cancer Center is, in addition to being a member of St. Jude Global, we are members of the Children Cancer International, the Union of International Cancer Control, and the United Nations Global Compact, the World Patient Alliance, as well as the WANGO. We have our UN SDGs, and this is where also, as a typical example, is our partnership with MSD, whom we thank very much for the support. And without them, the conference here wouldn't have been possible because they are the one who provided the fund in order for us to be able to do all the great work that had been done for the HPV. Also, we have our international presence in the UK, which was established in 2014. We are registered in the International Humanitarian City in 2018 in Dubai, and as well in France in 2022 and in the US as well. So how is the story behind the CCCL HPV programs? It started in one of the World Cancer Days where we had to do the virtual. We were at that time during COVID-19 and in the virtual world. So we had gathered all our survivors. Why do we talk about survivors? Because in 2018, we had created a club that was called the Champions Circle. And the Champions Circle, it gathers all the children who have finished their treatment and who want to support the center and who want to stay connected with the place that had saved their lives. So as such, we were in one of our meetings and we felt the need and the questions, the curiosity in these children in order to know more about the strategy, the global strategy for cervical cancer elimination. And this is where we had approached Dr. Bassel Bashir and Dr. Ghina Ghaziri, who Dr. Bassel is also with us today, who thankfully replied to our request, and we had started creating sessions for them to raise awareness and to answer all their concerns. So this is basically how we started in 2020. In the next slide, we will see how we had, in November, we had one of the sessions, and in January also, we had another, January 2021, we had another session. However, on April 7, we, at the World Health Day, we launched the program. And this is where we started to provide the vaccine for our champions. In no time, like what we will see in the other slide, is that in the upcoming slide, in 2021, in around 6 weeks, we had provided the vaccination for more than 40 champions who were with us. And this is where we have to protect our children from having or developing another type of cancer. So it followed a certain process where they have to register, and then our marketing and communication plan started, and we had administered around 100 youth with the vaccine and recorded testimonials about that. In 2022, we continued throughout the program. And when we received the grant from MSD, we started preparing for more activities related to that. So we had different panels in participation with MSD. And this also strengthened the point that Dr. Jirba'a just mentioned about the importance of partnership and the importance of collaborating all together. And also, we participated in one of the panels with MSD in Dubai Expo 2020, where we have some photos here and we saw how much are the UAE also advanced in raising awareness about the HPV. In 2023, we continued with our social media campaigns and awareness sessions, and we started in January during the Cervical Cancer Awareness Month. And we had our ongoing campaign, and also Rosalia and the team, they go to schools to raise awareness about the HPV. In 2024, we're continuing our social media campaign, and we added the HPV program to the CCCL application. So now anyone who wants to register, they can go directly to the application of the Children's Cancer Center, and they will see a dedicated section for the HPV program. And this is, we finally had this conference taking place because we had to come to postpone it from November till date. And we're continuing our awareness session. And I'd like to take a moment here to thank our Public Relations and External Affairs Department for being very active and for insisting to do the conference despite all the challenges and despite all the tension that we lived during the weekend. So I thank Rosalia and Imad for that, and all the CL team. Because also what Dr. Bernard mentioned, that everyone participated in their own way. And above all, I want to thank the audience and everyone to make this happen, because we have all together to work, collaborating for our children and in order for them to protect them from anything that might come up during later on. One more slide and we'll be done. This was related to the application. The last one is about our future plans, about more awareness sessions related to that. And we would love to have the collaboration of the ministry in order to have the HPV vaccine and program to develop related policies for that. And this, we can't do it alone, even no matter how we try, if we don't have the support of the, and under the umbrella of the Ministry of Public Health. So as part of our commitment and promise to all the cancer patients, we pledge to safeguard the lives of the childhood cancer survivors and to be their advocates through taking part of WHO Global Strategy. Thank you so much.
Thank you, Mrs. Hannah. Thank you so much. Lastly, we have Dr. Basil Bashir, who will be presenting on HPV gender-neutral vaccine, a need or an addition.
I can move through the slides on my own. So thank you all for being here, both in person and online. Very interesting topic I'll be presenting on today, which is applying gender neutrality to the HPV vaccine. Is it really a need or just an addition? So a brief outline of what I'll be talking about. I'm just briefly going to introduce HPV and then discuss HPV and its consequences, particularly pertaining to the cancers that are caused by HPV. I will then discuss the concept of gender neutrality and whether this is a need or an addition. And then finally, I will summarize the most important talking points from my presentation. So as we all know, HPV basically stands for human papillomavirus, which is by far the most common sexually transmitted disease worldwide, to which most sexually active men and women will be exposed to at some time during their sexual life. Now, although these viruses are sexually transmitted, we all know that sexual intercourse and penetration is not actually necessary for transmission. We do know that these viruses can be transmitted through very intimate contact and particularly mucosal to mucosal contact. And we also know that other sexual organs, including the mouth and the anus, can also be a source of transmission. In many cases, these viruses are asymptomatic, and this is why most people who actually get these viruses never even know about it. Of course, these viruses are very common. In the US alone, there are at least 6 million new cases diagnosed every year, and most of these cases are diagnosed in the younger age groups between the ages of 15 and 24. And again, most HPV will not eventually cause harm neither to men or women. It is only these in persistent infections with the most virulent and oncogenic strains of HPV, which may eventually develop into the cancers that we just discussed. Of course, a lot of these infections can resolve spontaneously because our body, and especially those patients who are immunocompetent and don't have any type of disease, in most of these patients, it's very easy for us to clear these infections. And most people who get infected with HPV actually clear these infections within the first year, with more than 90% of these patients clearing the infection within the first 2 years of infection. However, again, it is the infection with the most virulent strains that we actually worry the most about, as it is these infections which may eventually develop into cancers. Now, of course, there are more than 100 different types of HPV that were identified in the literature, but there are around 40 that affect the genital area. We do know about the low-risk subtypes, such as HPV 6 and 11, which cause the visible genital warts, which can cause actually significant morbidity, as well as the more virulent and oncogenic high-risk types, including HPV 16 and 18, and in particular 16, which can actually lead to different types of cancer. And when we talk about the cancers that are caused by HPV, of course, most of the early research done around HPV and HPV vaccination concentrated on HPV vaccine in its relation to prevention of cervical cancer, and rightfully so, because most of these cancers are actually associated with HPV infections. But what we can see here is that there are actually multiple other cancers that are also associated with HPV 16 and 18, including cancers of the anus, penis, oropharynx, vagina, and vulva. So as we can see, some of these cancers do also affect men, including cancers of the anus, cancers of the penis, which are exclusively found in men, as well as cancers of the oropharynx. And this is really where the concept of gender neutrality comes in. If this vaccine is given to girls in order to protect them against cervical cancer, it only makes sense to give these vaccines to boys to also protect them against anal cancers, penile cancers, and others. Now, of course, not all women who contract HPV will eventually go on to develop cervical cancer. It's only a certain percentage of these women who can't clear out the infections on their own and who are unvaccinated who may end up developing cervical cancer with time. But what actually distinguishes cervical cancer from all the other cancers that we discussed is that out of all the cancers, cervical cancer is actually the only one that has a recommended approved screening test. So in these cases, we can actually detect the cancer early if present, and we can treat at an early stage. Now, this is different than all the other cancers I discussed, including cancers of the penis, anus, and oropharynx, in which there is actually no approved recommended screening test. This basically means that when these diseases are diagnosed, they may be diagnosed at a later stage. And it's also more difficult to diagnose these diseases because they don't actually have any recommended screening tests. So again, this is where the concept of gender neutrality comes in. I mean, these diseases are also quite morbid and they actually don't have any screening tests. So if there's a vaccine available to prevent these diseases, I think that's great. Next, please. So as we can see here, there is also a very strong association between HPV and these cancers. It's not just a casual association. More than 60% of penile cancers are associated with HPV, more than 70% of oropharyngeal cancers, and more than 90% of anal cancers as well, similar to the association with cervical cancer. Now, we all know how the concept of immunization and vaccination works. Vaccination works through direct immunization, so patients who receive the vaccine are directly protected, but it also works through indirect herd immunity. So sexual partners of people who have received the vaccine will also have less risk of infection as they're having intercourse and having sexual contact with people who have already been vaccinated. So we have both a direct effect of the vaccine as well as the indirect effect of herd immunity. And just like direct vaccination works in women and indirect herd immunity works in women, the same applies for men as well. And we also have evidence of that from several studies. Next, please. So if you look at this recent study published in Lancet Infectious Diseases, looking at the prevalence of HPV in young men after the implementation of a gender-neutral HPV vaccination program in Australia, where this was given to, where the quadrivalent vaccine, which protects against 4 strains, was actually given to 13-year-old schoolboys in Australia, there was a significant reduction in the detection of these 4 strains from anal swabs, penile swabs, as well as oropharyngeal swabs in these young boys who eventually went on to become sexually active. And of course, the fact that there is less infection with these HPV automatically means that there's a lower risk of these patients developing cancer with time. Now, the concept of herd immunity, next slide, please, also works for men as well, just the same way that it works for women. So if we look at this study from Denmark, in which a non-gender neutral vaccination program or a girls-only vaccination program was applied to schoolgirls around 10 years ago, penile swabs taken from heterosexual men 10 years down the line also showed a significant reduction in the detection of these HPV strains from these penile swabs. Now, although this might speak against gender neutrality in the vaccine, basically these guys are protected as well, and we didn't detect any HPV in them. However, there was still a high rate of other strains of HPV and also from the less carcinogenic types. So again, this strengthens our resolve to apply gender neutrality to these vaccines as well. Now, unfortunately, although these vaccines were introduced at least 15 years ago, and as we just saw from the previous lectures, there is a very, very poor uptake of these vaccines worldwide. And of course, this is the importance of conferences such as these, basically to promote more and more uptake of these vaccines, particularly in low-income countries like Lebanon. Next, please. Now, perhaps another factor which can promote further use of these vaccines is the fact that in the last couple of years, there has been a change in the dosing schedules of these vaccines. And the main reason for that was in the earlier studies that were done on HPV vaccines, in which a 3-dose vaccination schedule was applied. A lot of these patients, particularly in lower income countries where some of these studies were conducted, such as Kenya or India or Chile, a lot of these patients never ended up taking the 3 doses because of logistical reasons or because of other reasons. And what researchers found was that even in those patients who ended up getting just 1 or 2 doses of these vaccines, the vaccine efficiency and the level of antibodies in these patients were almost identical to those who received the 3-dose vaccine. And so for this reason, over the last several years, there has been a change in the dosing schedule to basically, next slide, please, to basically imply that in the younger age groups, only 1 dose is required. In the catch-up age groups, perhaps 2 doses are required. And it's only in the immunocompromised patients, those who are HIV positive or those who have a weakened immune system, perhaps it's only in these patients where we need to go for the 3-dose schedule as well. So just to summarize the few points that I mentioned in my presentation, HPV vaccine is not a new vaccine. It's been around for at least 15 years. There has been a high uptake of HPV vaccine around the world with millions of doses taken. We all know it's safe. However, there's still a poor uptake in low to middle income countries, just like Lebanon. And we do have evidence from around the world that I just presented that, HPV vaccine in girls provides substantial direct immunity as well as substantial herd immunity in both unvaccinated girls and boys. And in my opinion, gender neutrality should be applied to these vaccination programs, as this will only strengthen direct immunity in boys and will also only strengthen and improve the herd immunity in both men and women. Applying gender neutrality to this vaccine can also help combat misinformation about this vaccine, minimize vaccine-related stigma, and also promote gender equity. Catch-up campaigns are very beneficial, and we know that. So even if young kids between the ages of 9 to 13 or 14 are unable to get this vaccine, even if they started their sexual life already, we still know that these vaccines can help. HPV vaccine, even after treatment of certain cancers, can offer protection. They can offer a reduction in recurrence rates and also less aggressive forms of cancer. And it's very important to keep in mind that even in those patients who do receive the vaccine, screening programs are still important as cancers can still develop. So, to basically answer the question that was posed in the title of my presentation, whether a gender-neutral vaccine is a need or an addition, it's certainly a need. Thank you.
Thank you so much, Dr. Bassel. Thank you so much. I'd like to see if any of the audience have any questions before we conclude, or if we have any online questions, Aya.
So the following question is from Kishori from Nepal. Is it possible for the HPV vaccine to be free of cost or accessible in low and middle income countries? Also, do you know any organization that can help with HPV?
Okay, I think Dr. Bernard, can you answer this question? It's for all the speakers. It's whoever.
When you vaccinate only girls, you have protection for girls and for a large percentage of boys. But there is the stigma and discrimination issue, and also a small percentage of better coverage when it is a gender-neutral vaccine. But when you want to vaccinate everyone, you have a double dose of vaccines that is required, because you're not vaccinating half the population, you're vaccinating all the population. So you really need to know how cost-effective your decision is. And we are confronted in decision-making in the low-middle income countries to such decisions. The same thing goes for 1 and 2-dose vaccine. So I'm not sure if I replied to the question. Would you like to add more?
I think the question was whether it's possible to provide these vaccines for free in low to middle income countries. Sure. I mean, I don't see a reason not to provide it for free, but I think this needs to be part of a national vaccination program. There needs to be support from ministries of health. There needs to be support from the private sector, perhaps some donated vaccines. I mean, it's not exactly my area of specialty, but I don't see the problem with that, basically.
Another person from the panelists would like also to join, Dr. Giuseppe, if you'd like to share your...
Yeah, no, because I think this is my area of expertise, area of work. Yes, as I mentioned earlier, Gavi, the Global Alliance for Vaccines, is able to provide subsidized vaccines to low and lower middle income countries. Of course, it's on a number of considerations. And it can be provided for as low as free to some eligible countries. The thing that I really want to highlight is that in any case, countries and governments need to be ready to make a commitment. Of course, Gavi subsidy. I think it lasts 1 or 3 or 5 years, depending on the status of the country. But countries need to later on step up and continue vaccination on their own, based on domestic resource mobilization and domestic finance. And WHO is the agency that provides technical support and technical guidance to governments to do that. Thank you.
The point that I tried to highlight is that when you want to vaccinate only girls and only one dose is X number of vaccines. And when you want to vaccinate 2 doses and gender neutral is X times 4. So you really need to go into cost effectiveness to make this kind of decision, especially that it is an expensive vaccine. Now, how we manage to make a low middle income country like Lebanon Gavi eligible was really a difficult exercise, and it took us 2 years. And this is how we can have a vaccine with less costs. But however, there is no free lunch. The country has to pay for that. And when the country has to pay for that in difficult circumstances, the country needs to make a decision based on those priorities.
Can I add something very quickly? I absolutely agree. I just wanted to mention that there are preliminary studies looking at herd immunity in populations vaccinating only girls or vaccinating both girls and boys. And it looks like that if you vaccinate only girls, you reach herd immunity by vaccinating at least 80% of the target population. However, if you vaccinate girls and boys, herd immunity is reached by vaccinating as little as 50% of the target population. So again, this is still preliminary. We don't have to advise one or the other strategy, but yes, I agree that there are considerations of economic nature, social, religious, spiritual, and everything that we have already mentioned today that one needs to consider before starting to vaccinate against HPV.
Thank you so much, Dr. Giuseppe, and thank you, Dr. Basil and Dr. Bernard. So I think this is the end of our panel.
There's another question.
There's another question.
Yes, another online question from an anonymous attendee. Once infected with HPV and cleared or imperceptible in testing, in the future, if he tests again, will he test positive from the same sexual relation?
The simple answer is yes. If the person is sexually active and he was active with a partner that does have this particular strain of HPV, then yes, for sure, even if his body was able to clear it the first time or her body does not necessarily mean that she or he will be able to do it the second time. So yes, they can get infected with these viruses, yes.
Thank you. That's it, yes.
Thank you so much. I would like to thank AUB MC and AUB for their support in making this conference happen, and I'll leave the floor to Zaina again.
Thank you so much, Rosalia, and thank you for our panelists for your valuable contributions and engaging dialogue. I would like to invite Dr. Hassan Salah once again for the closing speech. Thank you.
I will be very, very brief again. First, I'd like to thank the team organizing this conference. I would like to thank the distinguished speakers and the experts and the panels. I would like just to have a brief summary so that we can have a practical roadmap how to get to the targets that were mentioned. And I'm glad that these targets are addressed in several presentations. And I would like to quote Dr. Shirbeh, if he doesn't mind, that what is critical is partnership, collaboration, integration. I will add two, which is comprehensiveness and communication. I think these are very critical. We can have this meeting completed now, and we can go back to our business, but we need to have a very important impact of this conference. And I would like, with the permission of the group, to request a group meeting with His Excellency when he is back from his trip to put a roadmap how we are going to implement the plan that was discussed today, which will include awareness, which you are working on, Second is to have policies that would quote unquote mandate the vaccination because it's very critical. Number three, and I fully, support the fact that the vaccine is affordable but not free, because it's not easy to have it free. You should make it affordable, and then you should have the team between the governmental authorities, and we have experts in that field in public health, private sector, charity foundations, and patient advocates from parents, so that we can put the stakeholders together and put a steering committee to oversee the implementation of the plan. And I think this is a practical step that we can do together, as soon as we have the conclusion of this meeting, after all it is recorded as mentioned by our colleagues. I would like to thank you, and we will periodically give you update every quarter about what's happening with the plan. And I think it's very critical that we are accountable. I always say we can put a plan. If we are not accountable to its implementation, it will be a good exercise, but we want to make it more than a good exercise. Thank you. From my point of view, I think it's an excellent conference. It is short, but very, very productive. Thank you very much.
Thank you so much, Dr. Salah. Now I have the pleasure of inviting Mr. Imad Al-Haji, the PR and External Affairs Team Leader, to share some exciting news.
Actually, I will be very, very, very short, but to continue on Dr. Salah and Dr. Jerbea's recommendations and summaries, the CCCL is announcing today that we are going nationally with 4 partners hospital, AUBMC, CHN, Maasid, and Hamoud, to conduct a screening campaign, PAP smear screening campaign, that will start as soon as finalizing logistics with the hospitals. And in addition to the management and the board have decided to continue paying for the vaccine and providing the vaccine for our survivors, our childhood cancer survivors. Thank you all for coming. I hope you enjoyed the conference, and to many more. And thank you to MSD for being a great supporter of the CCCL HPV vaccine program. Thank you all, and I join.